request from our national clinical leads here in Healthcare Improvement Scotland to connect frontline clinicians interested in quality improvement with international leaders in the field of improvement. They asked that we make the sessions short, accessible and recorded to allow access at a time that suited them. And we're absolutely delighted, as you'll see later, that our QI connectors have expanded from clinicians to professionals and patient groups from all over the world. Jennifer, I'd like to hand you over now to Jennifer Graham, who will take you through the use of WebEx this afternoon. Good afternoon, Jennifer.
Thank you, and good afternoon, everyone, and welcome to today's session. So I've just got a couple of quick housekeeping slides to get us started. If you could please use the chat function you see on the right-hand side of your screen. If it's not visible at the moment, you just click on the icon, the top right-hand side. And we want the session to be really interactive. So I'll just talk you through about how to use the chat box in a moment. If you are having any technical difficulties, such as not being able to hear the presenter, or if you keep losing connection, if you could just please message the event manager using the chat function at the bottom right-hand side, or call the number that you see on the screen, which is *0. So these sessions are designed to be an interactive learning experience. So we do encourage you to use the chat function to share any questions, comments or ideas through the talk. There will be an opportunity for Q&A at the end of the session, and we'll be circulating some of the resources afterwards as well. So if you just click on that icon that you see there, that would be great. And when you just click to send to all participants and select and just type your message and then send. So here's the fun interactive part of QI Connect. We're delighted to say that we've got 17 countries who have actually registered to attend either the live session or the recording afterwards. So we want to just get a feeling for where you're all joining us from. So if you could just click on the icon that you see circled in red there on your screen, it just looks like a pen. And then click on the arrow that you'll see at the right-hand side. And then tell us where you're linking in from. Okay. I think maybe there's a problem with the annotations on today's session, so not to worry, we'll just press on. So I'm just going to hand you back to Brian, who's just going to tell you a bit more about the organisations and the countries who are linking into the session.
Great, thanks very much, Jennifer, and really sorry about the technical hitches today, folks. But delighted to say that QI Connect has now got an audience of more than 395 organisations, and we would normally have a competition at this point in time. Let me just see if the technology is working. Could someone just, this isn't a competition, folks, but could anyone just place their arrow on the Scottish flag? Okay, so it looks as though our competition is not going to work today. So we will come back to a competition the next episode of QI Connect. So just to remind you, when we started this series, we had only one slide with a series of logos from the partners who were joining us. We're now delighted to say that we have more than 13 slides of various organisations from across the world. Many of you are joining live today, and we're delighted with that. Wonderful to see the Arran Medical Group there. I spent the weekend in Arran just last weekend. Absolutely delighted to see so many folks from across England, the United Kingdom and further afield. And we're always delighted to see the universities join QI Connect during our series. And yet again today we have three new universities, bringing our total to 39 universities joining QI Connect today. And a big shout out to Durham University in the United Kingdom, the University of Otago in New Zealand, and also the Nurasan University in Thailand. So a big shout out to you. We're also delighted to record the session today, and that recording will be made available after the call. And this allows many of the QI connectors from across the world to use the recording in their teach backs and at a time that suits them. And just to remind folks on the call today that we have all of our recordings going back over the last 3 years available on our website, and that link is in front of you and will be made available after the call. Also delighted to continue a very strong relationship with the International Society for Quality, the ISQA organisation, and the QI Connect series is a part of the approved resources within the ISQA Fellowship Programme. And just a short introduction to the small but perfectly formed QI Connect team here. Delighted to have Jennifer, whom you've heard from on the call already, and also Olivia McDougall supporting QI Connect today. So thank you very much for your support. We're also delighted to have Eddie Turnbull, who is going to be our QI Connector questioner today. Eddie is the head of eHealth, the Scottish Government here in Scotland, and delighted to have you on the call, Eddie, and we'll speak to you a bit later on. Remember, QI Connect is very active on Twitter, and we have our hashtag HISQIConnect, so please follow us at HISQIConnect and tweet as you go through the call today. However, I would just like to introduce today's speaker. Today's speaker is one of the world's preeminent researchers in the field of patient safety and also in the field of health information technology. He is a professor of medicine at Harvard Medical School and a professor of health policy and management at the Harvard T.H. Chan School of Public Health, and a practicing clinician at the Brigham and Women's Hospital in Boston, Massachusetts. I'd like to welcome Professor David Bates. Good afternoon, David.
Thanks so much, Brian.
Great to have you on the call. And we're looking forward to hearing from you today, David. And I've just passed the ball, and the floor is yours.
Great. Well, it's a pleasure to speak with you today. And what I'm going to talk about is health IT policy development in the U.S., and then I'll also talk about supporting integrated clinical care. I'm going to start by going over where the United States was before starting a really big health IT policy intervention. And I'll talk about where we were with respect to quality, safety, and efficiency. I'll say a little bit about healthcare reform. Then I'm going to focus largely on health IT policy in the U.S. I'll focus on adoption and data exchange. Towards the end of the talk, I'm going to talk about using health information technology to improve care in the medical home with a specific focus on care coordination, and then I will wrap up. So, baseline, the quality of care that we've delivered is not as good as we've liked. And if you look at international comparisons, for example, from the Commonwealth Fund, the U.S. does not do well as say, the U.K. or many European countries. And, one of the key approaches that we're taking to try and improve the quality and safety and efficiency of care is to adopt health information technology. This has been a key focus of the Obama administration, and in President Obama's very first weekly address back in 2009, he said, to lower healthcare costs, cut medical errors, and improve care, we'll computerize the nation's health records in 5 years, saving billions of dollars in healthcare costs and countless lives. Around that time, an act called the HITECH Act was passed, which provided a lot of federal support for health information technology. And the notion of HITECH was that it would advance the tipping point, that by bringing together national coordination around healthcare IT, some grant programs, and some payment incentives to providers, there would be more trust by providers in health IT, and that would get people to feel comfortable adopting health information technology. Together with this was the concept of meaningful use, and before this legislation, meaningful use didn't really mean anything, so the concept had to be developed, and the notion was that incentives would be put in place that would get providers to adopt healthcare IT and then use it in ways to make quality and safety better. In the first, stage one of meaningful use, providers only had to capture and share data. So the notion was to have a very low bar. Then in 2013, the idea was that there'd be advanced care processes with decision support, and the hope was that by 2015, we'd be all the way to improved outcomes. David Blumenthal, who at the time was the National Coordinator for Healthcare IT, this is something that we didn't actually even have before the Bush administration, has argued that there are 3 key components to having a higher performing healthcare system. First, he suggested we need better information on what works and what doesn't. The second is the ability to rapidly apply knowledge to practice. And the third is changes in the financing and organization of care that reward physicians for considering costs and quality in decision making. And in particular, HIT should help us with developing better information about what works and what's not, and then help us with applying knowledge to practice. There's a lot of data suggesting that it takes between 7 and 15 years from when you find out that something works to when we actually start to do it, and pretty clearly narrowing that interval is a big opportunity. All of these recommendations were guided by something called the Health IT Policy Committee, which is a federal committee that I had the privilege of serving on. The policy committee's role was to make recommendations to the national coordinator on a policy framework for the development and adoption of a national HIT infrastructure, and then second, areas in which standards, implementation, specifications, and certification criteria were needed. There were 3 work groups: meaningful use, certification and adoption, and interoperability and information exchange. I served on the meaningful use group. Another thing that was put in place was that all health IT records were required to be certified. This was a new thing in the U.S., and it required quite a lot of work to set up the certification criteria. A few observations from working on this group. Everything has been conducted in the open, so all the policy meetings are open to the public, and they're all recorded. You can listen to them. There are stakeholders on the group from many, many different perspectives. So there are not only providers, but there are payers, there are patients, there are people who come at things from many different angles. The regulations have gotten greatly better after there was public commentary and response. They're all published in the Federal Register, and people have an opportunity to comment about them. Sometimes there's been really enormous time pressure in terms of developing them. To develop the first meaningful use criteria, just starting from a blank piece of paper, we only had around 3 weeks. So that was not easy. And I'd say that overall, it's not been possible to keep everyone happy, but it's been largely successful. Most recently, vendors and providers have been asking to slow things down, and consumer groups and insurers are saying keep going and move faster, suggesting that perhaps we've landed in about the right place. But overall, there's been consensus about the direction that things are going in. And there's no question that this has galvanized the interest of healthcare systems. When healthcare systems were asked what were their information technology priorities in 2011, meaningful use was just at the top of the list for everybody. And some other things which are, very important did not get very much attention at all. So it's clear that this got everybody's interest. Now, how does this work? Well, to get the payment incentives, a hospital or eligible provider, those are the 2 groups that are eligible to receive payment, they have to be a meaningful user to get payment incentives. And the idea was to change the focus from technology potential to clinician behavior. By law, meaningful users had to do just really 3 things. First, they had to use a certified electronic health record, and as I mentioned before, we had to set up certification criteria. The second was that they had to exchange health information, and the third was to report quality measures. All of these were a challenge, especially for providers in remote or rural areas. Often there wasn't anyone to exchange health information with at the beginning, who could receive it. And for many providers, it was challenging to figure out where to report their quality measures to, because there's not a central place. In some places like Massachusetts, we do have a central place, but that's not the case everywhere. Meaningful use had several objectives. The notion was to support new models of care, which were team-based, outcomes-oriented, with a focus on population management. The idea was that it would address national health priorities like the Million Hearts Initiative. The concept was that it would have broad applicability because meaningful use is a floor. You have to basically qualify to get the incentives. It had to apply to all different provider specialties, which was a challenge, especially for specialists and super specialists. It had to meet patient healthcare needs. It had to work in all areas of the country. The notion was that it would promote advancement and not be topped out or already driven by market forces. And then finally, it had to be achievable. And the notion was that mature standards would either be widely adopted or could be widely adopted by 2016. This slide shows what the meaningful use incentives were for eligible providers or individual doctors. And the way things worked is that you got more money early on, and it was set up largely as incentives, but there's actually a penalty of 1% per year with a maximum of 5% reimbursement that started in 2015. So there is both a carrot and a stick, and the goal was to get people to, again, to adopt. And this slide shows you the hospital data of how this worked. Basically, the message is that hospitals and eligible providers both paid a lot of attention to this, and we saw, really pretty broad national adoption. For hospitals, the levels are now well above 80%, and the same is true for eligible providers. And this slide just looks at it by type of hospital. There was a lot of concern on the policy front that some types of hospitals would be left out, specifically the small urban hospitals and critical access hospitals. But as you can see, what happened here is that a rising tide really did lift all of the boats. And if you look further out in time, those lines continue to just go up. Now, there were some issues with meaningful use, and David Klassen and I wrote a paper about this that was published in the New England Journal a couple of years ago. Among them are that much of the innovation in healthcare IT previously has come from a few sites, and all of those sites had homegrown records. So there wasn't very much innovation going on in vendor systems, and that, represents an issue. And yet, if you look at what is being implemented in the U.S., it's essentially all vendor systems. The notion that you could basically keep up with this with a homegrown system is, is an old one. There are almost no more homegrown systems in the U.S. But it's clear that we need support for innovation in the future, and we need to figure out how to accomplish that. We also made the point that it's essential to look at what organizations have implemented and not just what they said they would put in. And then finally, and this is true throughout health IT policy, linking things with external incentives are going to be pivotal, and I'll come back to that when I talk about healthcare reform, because for this to really work and for providers to do the right things in terms of quality and safety, there have to be payment incentives for doing better along those lines. So if you look at healthcare reform more broadly in the U.S., the main legislation has been the Affordable Care Act, that's sometimes called Obamacare. The biggest thing that this act did was to provide access to all patients. We were actually the only industrialized nation that did not do that. But it also includes incentives to improve costs, quality, and efficiency. It sets up this concept of accountable care organizations, which are organizations that agree to take on the care of a population of patients that they then are accountable for what they're doing. It also introduced the concept of bundling, in which one organization would agree to provide a bundle of services, say cardiac surgery or spine surgery, for a specific price. The big issues with the Affordable Care Act are really whether or not the pressure on costs will be sufficient. Most policy experts think that's probably that they're probably not. This whole area is obviously, for anyone who reads a newspaper or looks at a blog, is still politically contentious, with a large part of our country thinking that this is a terrible thing. We don't still have a strong movement to single payer, but I think it's actually pretty clear that we will not go back. Now that everybody has insurance, there's a lot of data that people are better off, and I think we will, we'll move forward from where we are now. I just wanted to spend a minute just telling you about where I work in practice, which is at Partners Healthcare, and I thought I'd tell you about where we are and what our current state is. We're the biggest integrated delivery system in New England, and we serve about 3 million people. All of our physicians and patients are in one system. We've just implemented Epic, which is a vendor electronic health record. It's the biggest one in this country. We spent $1.3 billion on it. We're in the process of rolling it out throughout our network, which will take a few years, although the 2 big hospitals are now up. Mass General just went up yesterday. We do have complete data exchange within Partners, which is really terrific, so I can look at any piece of information generated pretty much anywhere else within Partners, and that's been very valuable. We have at least 400,000 patients who have personal health records. That figure just keeps going up very rapidly, and we, at least historically, have had very strong clinical decision support. Nationally, if you look at who's struggling, it's people who are not like us. So it's not that the networks have all done pretty well, but small hospitals, disproportionate share hospitals are still having a hard time, and that's especially true if they don't have relationships with larger entities. And small practices are also having a hard time, and there's evidence that many practices actually become less efficient after they put in electronic health record, especially if they don't make substantial changes to their workflow. The other big area that is not working as well as one might like is clinical data exchange, which continues to be a struggle. That's mostly been done through something that's called Regional Health Information Organizations, or RIOs, and they are public clearinghouses for data. They need a public support if they're going to be successful from the business perspective, and right now there is not a plan to give that to them. So that has been the place where I would say this whole effort has fallen the most short. Now I'm going to take you into some data about how things are going. This is a study that was led by Jane Metzger et al. And was published in Health Affairs in 2010, and we looked at what medication-related decision support hospitals had actually put in place in the U.S. The group that led this work built a computer order entry flight simulator, and hospitals were asked to put in orders that had the potential to cause a problem, that either had caused a death somewhere or had caused serious harm. In the initial round with this, we got 62 hospitals to voluntarily participate. When we found that simulation detected only 53% of the orders which would have been fatal, it had actually killed someone, so not a very good performance. And it detected only between 10 and 82% of orders that would have caused serious adverse drug events. Furthermore, there was almost no relationship with vendor. People had the idea that if you pick the right vendor, that things would be okay. That pretty clearly is not the case. This slide shows the distribution by vendor, and the point is that every vendor had performance that was very good, and every vendor had performance that was not so good. And most organizations had no idea where they were on this spectrum. We've recently gotten federal support from the Agency for Healthcare Research and Quality to update this test, to add more decision support to it, and and also to add some more categories of testing. And I think this is something that will be applicable in the United Kingdom as well as it has been in the States. In the U.S. now, around 2,000 hospitals have taken the test. I think I have the number correct, but it's much larger than where we started with the initial ones. The other thing point that I should make is that hospitals do improve their performance. So when they find that they are missing something, they are really motivated to basically make changes to their decision support. Now I'm going to change gears a little bit, and I'm going to talk about the patient-centered medical home and health information technology. There's a lot of belief in the United States that if we are really going to make care better in the ambulatory setting, the way that we'll do that is by implementing what's called the patient-centered medical home. And there are a lot of things that are different about the medical home, notably that care is delivered by a team as opposed to just by a doctor. We argued, I wrote a paper with Asaf Bitton on the future of HIT in the medical home that was published in Health Affairs in 2010. We argued that there were 7 major areas of decision support that were especially important. And I'm going to focus on clinical decision support, registries, team care, and personal health records. Other areas that we also think are important are using Health IT to help better manage care transitions, telehealth, and then to do a quality measurement. But in the interest of time, I'm not going to talk about those today. So what about decision support? Well, decision support can be delivered either within the electronic health record or within the personal health record. There's increasing evidence that suggests that if you give decision support directly to the patient, it may be even more effective than giving it just to the provider. Decision support can improve processes and intermediate care outcomes, although there's less data about more distal outcomes. It can reduce the frequency of adverse drug events, but it has some downsides. Many providers, if left to their own devices, won't turn it on, or sometimes will even turn it off. And we actually don't allow providers to make individual level decisions about this. One thing I will say is that most electronic health records today do not include very good decision support. We need better decision support in a few areas around care transitions, around medications, and around management of chronic diseases. Those are the places where I think we'll get the most benefit early on. I want to give you one example of a tool that we built here that helps improve performance with the electronic health record, and this is work that was led by Adam Wright. So Adam Wright led a study which is called MAPLE. What MAPLE does is it looks through the electronic health record and it looks for diagnoses that it appears that the patient has, but which are not on the patient's problem list. And the problem list is really important because much of quality improvement really requires having a patient's problems documented. So what Adam did was to look through the record, look at the coding diagnoses, at the labs, at the drugs, and then try and infer what diagnoses a patient had. We studied this in a trial called the MAPLE trial and showed that we were able to increase the number of problems by 48%, and these are all ones that are really important in terms of decision support. So this is an example of a kind of tool that I believe really will be helpful in terms of making care better. And it was actually relatively simple to put in place. The tool is all open source and it's broadly available. I think the future with decision support is that we ought to be able to implement much more complex rules. Most of the things that we're doing today are very simple. We ought to be able to take into account a wide array of factors. Some of the issues around what's going on with an individual patient. We ought to be able to leverage new analytic approaches like machine learning. The computer ought to be thinking along with the provider, and eventually I think we'll want to be more directive in certain situations. And I think it'll be helpful if there are collective repositories to draw from, the decision support can be treated as web services and can sit outside your electronic health record and be brought in. Registries are also a really important tool. They can be very helpful for managing populations. They need a variety of functions, so they ought to have good front-end views. You should be able to readily generate lists. They should be usable by multiple providers within the team. Issues with registries have been that highly functional multi-disease tools are not available, and most of our patients come with more than one disease. Some of the key needs include building the ability to abstract registry data from existing electronic records, training staff to interface with registries. It shouldn't just be the doctors. And then we should have really strong registry tools, and I'll show you some of those. So this is a tool called Registry Population Manager, which was built by a team led by Adrian Zai at Mass General. And this particular tool basically takes all your patients with diabetes, puts them in one place. It prioritizes them according to how abnormal their A1C is. And then there's some tools that do some auto-summarization for the provider, so you can mouse over an individual patient's name and see what they need to have done. There's some tick boxes over on the side so that you can request that a letter go out to the patient or that the patient get called, for example. And it also includes a lot of information that lets us get at barriers to care. Much of the time when people are not doing well, it turns out that there are some significant barriers to care, and we historically have not had good places in the record to put these. This is one place where these can be captured. Adrian also built a tool called Registry Population Manager, and this has had a big impact on process efficiency. This was studied at one site in the partner system. He looked at the time for a diabetes nurse manager to identify whether a reminder letter should be sent. Without RPM, the nurse working on this was able to process 10 to 30 patients per hour. With it, it went up to 300 patients per hour. So just a huge improvement in efficiency, and the nurse was able to cover many, many more patients. This next slide shows a tool from Kaiser, which is one approach to showing providers which of their patients have multiple conditions. So here, you can look through a list of your patients and see which of them have, for example, diabetes, cardiovascular disease, heart disease, hypertension, and CKD. And it also lets you go into that individual patient and drill down and figure out, are they getting the care that they need, and if not, what needs to be done. Team care, I think, also will be really important. I think team care is going to be pivotal for overall, for high levels of overall primary patient-centered medical home and system performance. I think it might be the most important at all, and most of this is relationship-centered. So think of the patient with a hemoglobin A1C of 13 or 14. The provider doesn't need reminders about that patient. Someone needs to work with that patient one-on-one to figure out what their issues are. Now today, most electronic health records don't really support team care very well, and there have been limited incentives for non-physician providers to engage in team care. Ann O'Malley, who's at the Center for Healthcare Systems Change, has done some very nice work on electronic health records and care coordination. And her team evaluated a number of electronic records and suggested that there were 5 main dimensions that need to be dealt with in an electronic health record to enable it to manage care coordination well. Those were tools to sort out continuity within the team, to allow documentation of information, to process referrals both in and out, to share care plans with other providers, and then to assist with transitions. And she noted that all of this has to be available to all team members, and all team members have to be rewarded for engaging in this. Today's records just do not do a good job with many of these things, so it's actually hard to figure out exactly who is on the team in many records. processing referrals is often cumbersome. Most records do not really have good places for recording care plans, and certainly not with sharing them. And things with transitions are still really in their infancy. Personal health records, I think, are going to be a very important tool for doing better with care. They can increase patient engagement and self-efficacy. They can deliver portable, real-time information to patients. Many organizations are developing personal health records. Both Microsoft and Google had well-chronicled forays into this space. That didn't go too well for either of them. And I think the best architecture for personal health records is that they need to be linked to the patient's electronic health record. Without that, I just don't think they work that well. Other issues with them have included lack of patient uptake, issues with low health literacy, and provider hesitancy toward using them. But, you know, we've seen a lot of benefit. We have, this number should actually be over 400,000. It keeps changing every time I use the slide. But what we found is that with little stimulation, 15% of patients sign up, but some practices have enrolled 60 or 70% of their patients. The core functionalities are ask a question, ask for a referral, get a med refill, check your labs. Notably, 70% of queries can be handled by someone who's not a physician. We pretty clearly need to bolster the functionality for patients with chronic diseases. The personal health record really looks the same whether or not you have diabetes or hypertension. It's not too personalized today, and it should be going forward. Here's some data from Kaiser on their experience with personal health records, and they found that when they put them in place, the annual office visit rate fell by about a quarter. And the figures were similar in primary and specialty care, and yet the total patient contact rate went up by 8%, and quality and satisfaction either maintained or got somewhat better. So what is it going to take to transform care? Well, with respect to safety, I think the key issue is making our essential processes more reliable, and that will involve using new approaches like computer order entry and like barcoding. It will also involve using checklists routinely for things like central line infection rates, noting Peter Pronovost's work, the rates of ventilator-associated pneumonia, surgical checklists in the operating room. But I think we'll likely need dozens of checklists. We also need to be able to better measure our performance in an ongoing way. Most organizations don't do a good job with measuring safety. In terms of quality, I think you need an electronic health record and three basic things in addition. First is clinical decision support at the point of care. Second is registry tools, and third is tools to enable team care. And I think we should actually be measuring performance on lots of measures. The right number is probably hundreds, and then there should be transparency as to how organizations and providers are doing. So to wrap up, I would submit that U.S. healthcare has a lot of room for improvement in efficiency, safety, and quality. The overall HIT policy direction taken so far has been terrific. The early returns are positive, but the jury's still out. I do think that information technology will become ubiquitous in healthcare, that we're near a tipping point. Electronic prescribing is one early big win, and yet adoption is just the beginning. I believe that electronic health records and HIT more broadly can and will provide major benefits in all three areas, safety, quality, and efficiency. Safety is perhaps the most straightforward with checklists and reliable processes. Quality improvement, though, is achievable in HIT with many domains. The efficiency benefits are the least well demonstrated, and linkages with incentives are especially key. Some of the key frontiers in this area, I think, are figuring out how to engage patients using HIT tools, doing a better job with care coordination, and a whole nother topic, but leveraging some of the big things that are going on in information technology, including social media, mobile technologies, big data, and cloud. I would say there's lots to be learned about how to get benefits. HIT is just a tool. It's part of a program, but I would submit that nearly every other effort to improve safety, quality, or efficiency will rely in some way on healthcare IT. And for organizations that are getting started in this area, getting the right decision support in place is central, and that's one of the first places to start. I'll close with a quote from Albert Einstein, who said that insanity is doing the same things the same way and expecting different results. And I'll just show you this cartoon. I hope we're here before too long. It says it was done by a doctor. It's called Orders. And I will stop there.
David, thank you so much. That was an amazing run through the terrific developments in the US. The chat box has been alive throughout that, and I'll come back to some questions from some of our participants. Delighted to see so many participants from across the world, including colleagues in Australia staying up, and David Grayson over in New Zealand staying up for the call as well. So, but let's first of all go back to Eddie Turnbull. Good afternoon, Eddie.
Good afternoon, everybody. As you say, David, thank you for an excellent presentation, and actually addressing it from the point of view of the levers for change and the approaches that have been taken, rather than actually focusing on the technology aspects of it, although you did touch on that towards the end. From my point of view, a point where I think in Scotland, but clearly worldwide, the expectations of what IT can deliver in the health and care domains never been greater. Actually, so there's the expectation from health and care workers, and there's now increased expectations from citizens of how IT can help support their health and care. So at a point when actually the opportunity to invest is actually limited, because we don't have the funds now that perhaps we had a few years ago. You know, where do you think that technology can have the greatest impact on quality and cost effectiveness of health care? And any thoughts on how you prioritise activity in this domain?
Sure. So one of the earliest wins really is in medication safety in both the inpatient and the outpatient setting, and also in medication-related efficiency. So if you can computerize prescribing and then put in place the right set of decision support, there's strong evidence that you can improve medication safety a good deal, and you can also make suggestions about using medications more efficiently that will make care better. So that's one place where where I would start.
Yeah, and coming back on that, in Scotland, absolutely agree, and I'm sure colleagues will, who are also connected to the call for Scotland, that is exactly where we're going around introducing hospital electronic prescribing and medications administration, IT solutions in the boards in Scotland. So if you take that, David, on one side and the benefits that brings for patient safety, what about the challenge that I'm faced with equally is to give patients greater access to their health information and allow them, as you were saying in your presentation, to participate and actually provide them information that can be shared from the personal health record into the electronic health record.
Well, so I think that also is very powerful, and potentially transformative. It takes a little while to get people to sign up for the personal health records, but once they do, the whole way that care is delivered really starts to change. Much more can be done virtually. You can get rid of a lot of unnecessary visits. There are things that can be done by, say, taking a picture of a rash that you have and sending that to your provider. And I think in the longer run, getting patients engaged and showing them their information will really change the way that we do things.
Okay. Thank you very much, Eddie, and thanks very much for that, David. I think I recall I sat in with you in one of your clinics in Brigham about 8 years ago when I was living in Boston, and I was very impressed with how your patients were able to access their records and access you from both wherever they were in the United States. It was very impressive. I'd like to go to some of the questions on the chat. Welcome to our colleagues in NHS Lothian who are joining in a group over in Edinburgh this afternoon, and to Alex McMahon, their newly appointed nurse director. Welcome to the call, Alex. And Alex is asking, of that big list of things that have contributed to the advances in the United States in terms of uptake and use of health information technology, what made it work so quickly? Was it the money? Was it willingness? Was it behaviour change? Was it expectation? What would you say made it work so quickly, David?
I think it was really the financial incentives. I mean, the issue going in was that the people who had to invest in electronic health records were the doctors, and yet in analyses that we and others did, if you look to see who got the financial benefit, that was going mostly to the payers and the purchasers. So you're asking, one group to spend a lot of money on something that was not going to benefit them themselves directly. I do think it's really important to going forward too to set up the payment incentives so that providers are rewarded for delivering higher quality and safer care, and obviously, the UK has led in that regard with the with the QOF and with approaches like that. But yeah, I think the very first thing is to align the payment incentives.
Yeah, great. Thanks very much, David. Just to go to an earlier question from Andrew Winter, who, although he's the e-health clinical lead in Greater Glasgow and Clyde, is actually dialing in from Australia for the call. That seems like a difficult route, Andrew. But Andrew was asking about some of the incentive schemes. He said the incentive scheme very small if it's up to 48,000 per provider. How would that influence huge organisations like Partners?
Yeah. I mean, we basically got all our providers to make the switch. That was big enough. There's been a lot of debate on how big do the incentives have to be, but the existing evidence suggests that even modest incentives result in pretty substantial behavior change. Most healthcare organizations now, at least in the U.S., have pretty tight margins. So anything like this is the sort of thing that organizations will pay attention to.
Yeah, great. Thanks, David. Let's jump from the macro right down to the nitty-gritty of making change happen. And we've got a question here from Alistair Philp, who's an improvement advisor at Scottish Government. As you know, David, we are very familiar with the Institute for Healthcare Improvement and the Plan, Do, Study, Act cycle, small tests of change. And Alistair is asking, how do we improve workflow or processes through small incremental tests if it's dependent on IT systems, which themselves tend to ossify processes? How have you gone about making those small tests of change?
Well, so, I think that the big health IT implementations are something of an act of faith, and you have to say, okay, we're going to do these broad things, but quality improvement approaches are still essential, and it is much easier to run a set of PDSA cycles. Once it's easy for you to get the data, which these electronic health records can really enable. So I think the two are absolutely complementary, and you really need to do both. Thanks,
David. I guess there's a couple of comments in the chat box around incentivization. Thanks. Andrew, for your comments, Andrew from Consart Consulting, around how we might incentivize either GPs or consultants. Thanks also to Alec Murray from Spike Support Service. One of the things that Alex is making clear is that the difficulties in getting information to flow between systems, between providers. And I guess you described, David, how the health information exchanges facilitated that. Yeah,
so that continues to be the biggest thing in the U.S. that is still not working that well. And it's not so much a technical issue. It really is an issue of you know, again, setting things up so that things work from the business perspective. You know, we've studied the regional health information organizations in this country, and there are about 120 of them. None of them was making money. So that suggests that really you need some public investment in setting up information exchange, and that should be a priority for governments.
Great, thanks, David. We've got some comments here. So Karen Facey, who's Honorary Research Fellow at University of Edinburgh. David Bates on the call here also holds an honorary chair at Edinburgh University, and Edinburgh University is part of the partnership that forms the FAR Institute. And Karen's making the point that bringing together health and social care for the purposes of understanding the systems of health and social care and improving care is an evolving field in Scotland. David, experience of bringing together health and social care data in the US?
So we're still in early days with doing that, but I think that there's an enormous amount of potential value in doing that. If you, for example, look at who our high-cost patients are. The high-cost patients account for roughly half of costs, and you know, within that group, you know, many of them have very, very substantial social care issues and needs, and it's become increasingly clear that if you don't deal with those needs, you basically can't manage the rest of their issues as well. So there's a big focus, you know, in this country on bringing together you know, those things. I would say it's still early days. There are, you know, privacy issues with bringing together data from different sources, but that should definitely be the vision. And there are a lot of things that we'll be able to work out once we do bring together these types of data.
Wonderful. I'd just like to thank you, David, for your talk today, and also a big thank you to Eddie Turnbull, the Head of eHealth from Scottish Government, and also to the team here at Healthcare Improvement Scotland. Wonderful resources that people have chatted in. We'll make sure that the chat is fully available and all the links to the suggested resources. Absolutely wonderful session today. Just to remind you that our next QI Connect session is with Jeff Mulgan. Jeff is the Chief Executive of Nesta, which is the UK's Innovation Foundation. Jeff has an amazing story to tell about innovation, about engagement in education and social movements. Really looking forward to that session on the 19th of April. And just to remind everyone again, this is the lineup for 2016 QI Connect series. Looking forward to you joining us at the next session. Good afternoon and enjoy the rest of your day.
Thanks so much.
Thanks, David.